Morning, everyone. So I was talking with Dave Taubin, who was complaining about following the very eloquent Jane Ballantyne, and somehow I follow James Brown. I don't know about the fairness in that setup. As Jim just said, this is the second year that I presented here. Last year I presented primarily on what psychological treatments for chronic pain aim to achieve, what they look like. And when I was re-invited to come speak, I was faced with an interesting dilemma, which was how to talk again about psychological treatments in a way that wasn't the same old talk that I gave last year, because that would be poor form, I think. And as I listened to the talks this morning, instead of trying to think of another talk that I could come up with to speak about these issues, I was wondering, should I talk about the small amount of work we've done in opioids, trying to define what the scope of the problem is in chronic pain? Should I talk a bit more about psychology? Should I sit here and do psychological treatments with all of you? Yes, all right. That's not one that I decided, but maybe we can do that over lunch. What I thought that I would talk about here is to try and give you an in-depth look at one kind of psychological treatment, something called acceptance and commitment therapy, or ACT, as Dr. Taubin mentioned in his talk earlier. And not only talk about what its primary tenets are, if you will, or its primary goals or assumptions, but talk about the ways that ourselves and others have tried to take a good hard look at these therapies in order to try and determine not only how well they work on average, but how well they work when we hold our data's feet to the fire, in effect, to try and be very stringent about success criteria or failure criteria, and also to try and discover or highlight, not discover, highlight how it is that these treatments seem to work. And I hope what I've done is pick the right talk for today. So I'll be keeping my eye on all of you, and if I start to see people nodding off, I'll know I need to move along more swiftly, and that you guys will let me know if I've made the right choice or not. So I'm a clinical psychologist by training. As I said last year, it's a real pleasure to be the only clinical psychologist on the day's agenda, which means I get to speak for the field and no one gets to disagree. And I also genuinely am honored to be a part of such a stellar lineup. This little conference that you all have hits so far above its weight, or punches so far above its weight in terms of quality, that everybody involved should be incredibly proud of what has been accomplished here. So ACT, or acceptance and commitment therapy, is a behavioral approach. It intends to alter patient behavior such that it is more effective over the longer term. It's a close cousin of cognitive behavioral therapy, which is probably the most well-known psychological treatment that's out there. And both CBT and ACT share a common lineage, which is this old operant behavioral theory that folks like Skinner wrote about, and also Watson, that derives from a philosophical approach that people like James wrote about. So there's a long history here of what ACT is or where it comes from. And where I thought I would start, after saying I have some disclosures, which is only that there's external funders for my research. I don't think any of these external funders or the funding that I've received from them is going to influence the talk that I have here to give you today. Where I thought that I would start is by highlighting for you my understanding of what the primary goal of psychological treatments, or ACT, is. And that primary goal that demarcates successful treatment from failed treatment, is whether or not patients at the end of treatment are engaging in meaningful, effective, vital activities of daily living in a manner that is sufficient for their needs. Something we might say, we might shorten that to just say they're taking effective action. Quality of life is sufficient for their needs. This is the hallmark, very clearly stated goal of ACT, and it's a goal of other therapeutic approaches as well. Underneath this goal, or this litmus test of successful treatment, are at least three assumptions. The first assumption here is a somewhat circular one, but is nonetheless important, I think, which is that effective action only happens when effective action happens. In other words, it is not something that is reported to us, it's not some feeling that is felt, but that effective action only happens when effective action happens. This is not really a new idea in the behavioral treatment of chronic pain, and it was stated in another way about 40 years ago, which was something like this. We can conceptualize the problem of pain not necessarily as a problem of pain, but a problem of responding to pain, or responding to other aversive circumstances in one's life. And the problem with these responses is that as they become increasingly directed in the direction of pain avoidance or negative feeling avoidance, That comes at a cost, and that cost is that they're no longer directed towards these areas of life that actually matter, that there are some decisions going on, there's some choice points that are happening. Attention-grabbing and highly salient nature of pain and things like depression, anxiety, and histories of trauma, these organize behavior in a direction of avoidance. That comes at a cost of quality of life. The earliest this was stated, as far as I know, was in this wonderful little yellow book written by Bill Fordyce, published in 1976. I was lucky enough about a decade ago to come across an original copy of this book, and I bought it, and it has that lovely smell of old library books. So it has I have a very soft spot in my heart for this book. If you haven't had the chance to read it and you're interested in this area, you will find no better introduction to this idea. Some of us felt that this book was still so relevant now that we had it republished about 18 months ago with invited commentaries from a number of stellar contributors in the field. And as an editor on this, I had the chance both to reread the book and to reread every commentary, and I can say hand on heart, again, this book is a wonderful investment of your time. I'm not saying that because I get any of the money from the book sales. Amongst the 5 editors, they offered us to split 1%. And we thought that money would perhaps be best redonated into the Fordyce Fund at the University of Washington, which they use for research purposes. So I'm not trying to sell books, at least not for my own personal gain. Thanks. Yeah, absolutely. No problem. It was Chris Main's idea. I wish it was mine. So assumption 1 of this, effective living only happens when effective living happens. Assumption 2 is that effective living does not bring with it a necessary set of feelings. Particularly not a necessary set of positive feelings. It doesn't require feeling good or happy or relaxed, and it certainly doesn't require being pain-free. Those of you who are parents out there, I would ask you to reflect on your experiences of parenting. Thank you for laughing at the punchline before I even delivered it. Parenting is not something that always entails feelings of goodness, right? Or feelings of being pain-free. My daughter's 11 and is just starting the preteen stuff, so there's a whole new kind of pain in my life at this point in time. If you have a spouse in your life or a partner or someone who you care deeply about, these super important things in human lives do not ever come with the absence of aversive feelings. And that's important for us to remember. The important stuff is sometimes the stuff that hurts most or that hurts with a degree of frequency. Third assumption here is that effective living comes with having options for behavior. Or in the old parlance of Skinner and these old operant behavior analysts, comes from having a broad behavioral repertoire and being flexible in our choices such that the choices that we make are best able to lead us in an important direction. I'll give you an example of this, of all 3 of these. This is an individual experiencing pain. I think we have a number of seasoned clinicians in the room here who can look at that and say clearly that's what's going on, right? It's a person experiencing pain, and this person experiencing pain is having a thought that I can't go on. Some conceptualizations of this situation would say we must remove this experience and these cognitions before behavior can effectively move forward. What I think we're starting to understand in behavioral approaches to chronic illness writ large is that the experiences themselves are not necessarily the problem. The problem is the set of responses to these experiences that occur. And the problems, particularly from the perspective of ACT, may be conceptualized as being one of 3 kinds of response classes. The first is that when these experiences are experienced as being absolutely overwhelming, individuals feel like there is nothing else going on in their reality at that point in time but this experience of pain and this experience of a negative cognition. That sets the stage for trouble. When these experiences are met with absolute, pronounced, stonewalled unwillingness to experience what is being experienced, that sets the stage for tremendous difficulties. And when there is a failure, if you will, in clarity in what is important, when important activities of daily living, such as social activities, caregiving activities, independence activities, and the like, are supplanted by efforts to get rid of these undesired experiences, that sets the stage for problems. And we might say that the problems can be conceptualized as something like stopping behavior. Life stops. And in the clinical work that I do, when patients describe this experience of life having stopped, it is never discussed in glowing terms or as a desired outcome. Patients say things like, I feel trapped, stuck, like I have no other option. When we talk about things like opioids, I've had so many patients tell me, I ask them, do your opioids help? Or your analgesic medications writ large help? Do they reduce your pain? They do that sometimes, okay, not super well. Do they help you engage in important activities in your daily life? The most common answer I get, and this is clinical experience, so take it with a grain of salt, is people saying, no, they don't help me do more, but gosh, they help me care less. Man, I don't think those are the outcomes we're looking for, right? These are not the outcomes we are seeking to achieve. From the perspective of this model, we can start same patient, same thought, and we can try and alter responses to these thoughts. We can try and ask people to maintain contact with these thoughts or with these experiences, but also broaden out that awareness so that they also are aware of other things going on out there. That's a simple definition of what we mean by mindfulness when we're talking about it clinically. Be aware of what's happening now. Be aware of broader stuff too, because the broader stuff might be important. We can ask people to, or we can use our clinical technologies to try and foster a sense of willingness to experience what one is experiencing. Something like, I'm willing to experience this pain that I have right now in the service of this important activity in my life. And again, in my clinical experience, the ones that come up most often in our people with pain are things like grandparents taking care of grandkids and parents engaging in other important activities in their children's lives. I'm willing to experience this pain, to walk my daughter down the aisle today because this is important to me, as an example. And also, we can really work on trying to get awareness of what's important, but also persistence in values-based activities. Try and get people moving slowly and regularly and gradually in the direction of doing more activities that matter or in a more regular or uniform way, such that quality of life becomes more sufficient for their needs. And at a theoretical level, this model might lead to the same old spot that is never removed as a behavioral option, but it also might lead to something we might describe as carrying on behavior or moving forward behavior. And the thing with carrying on behavior is that you can use a lot of clip art to illustrate it. The thing with carrying on behavior, in addition to the clip art advantage, is that the form of the behavior can have, it can take many forms. It can be things like recreational behavior, romantic behavior, dog walking behavior, caregiving behavior, extreme sport activity behavior, exercise behavior. In other words, behavioral options are broadened, and this is what we know from our 100-year-old discipline of psychology. When people have more options for behavior and are not trapped, quality of life tends to be better. The other thing here is that stopping behavior. There's more options for stopping behavior. And it may start to take the form of things like slowing down, smelling the roses, enjoying moments in life. In all of my time as a clinical psychologist, I have never encountered a patient group that is harder on themselves than these individuals who have chronic pain. They are sometimes their absolute worst enemy. And so giving them a little bit of freedom to slow down on purpose can be of some benefit. That's theoretically what this treatment approach is about. And what I would like to do now is just move into the ways that we have tried to evaluate whether or not this treatment approach seems to work in chronic pain, and the work that we've done to try and evaluate potentially how it works or for whom it works for. We have, at this point in time, something like 17 trials of ACT. And again, it sits in this family of cognitive behavioral therapy for which there are hundreds of trials at this point in time. The longest follow-up study that I'm aware of is one we published a couple of years ago now, a 3-year follow-up study that was published in Behavior Research and Therapy. We summarize those outcomes as effect sizes, and the effect sizes are displayed here. Many people in this room are probably familiar with effect sizes. Some people are maybe not. So let me just summarize very quickly what an effect size is. An effect size converts units of raw change into units of standard deviation change between your two assessment points, pre-treatment and post-treatment. What that means, hopefully in straightforward terms, is that if there's an effect size of 1, that means the average patient shifted 1 standard deviation from the beginning of treatment to the end of treatment or the beginning of treatment to follow-up. By convention, because this old statistician Jacob Cohen told us this was how it was so, a small effect size is from 0.2 to 0.5, and colloquially, that's an effect size that really, as Cohen said, only an expert would notice the difference here in the change. Small effect size, 0.2 to 0.5. Large effect size, 0.8 and above. Colloquially, Cohen said that's a change that even a non-expert would notice. And then from 0.5 to 0.8, we have a medium effect size. And if you look across the treatment outcome literature writ large, most treatments that we have as humans give us about a medium effect size on average. Meaning that on average, pre-treatment to follow-up, pre-treatment to post-treatment, individuals are shifting about a half a standard deviation. On our y-axis here are our various outcome measures, our various proxies, and this is an imperfect science, our various proxies of meaningful, effective, and vital living are there. We don't have a great litmus test actually for that, but we have proxies at this point. Things like, are people more willing to experience the pain that they've got? Are their behaviors less discrepant with areas of importance? What's pain intensity? It's not what we're treating, but maybe let's track it and see if it changes. Depression, pain-related fear, physical disability, psychosocial disability, and pain-related medical visits. And if you just eyeball these is not RCT data, but these are controlled effect sizes for within participant correlation. You see on average one other thing I forgot. Our 3-month follow-up is the solid bar here. Our 3-year follow-up is the dashed bar here. If we just pay attention to the dashed bar for a little bit of time, see that on average, we're getting a medium effect size, 3-year follow-up, and there's reasonably good maintenance of treatment gains. Hopefully that's relevant. So at one level, what we can say is that our work is done. But hold on, I'll tell you why that's not true. The American Psychological Association's Division of Clinical Psychology maintains a list of empirically supported treatments. This list was put together essentially as a consumer guide to treatments out there. The Division of Clinical Psychology grades treatments in one of 3 ways. It says either there's no evidence at all, there's modest evidence, or what they used to call a promising or emerging treatment, and there's strong evidence, what they used to call an established or a well-established treatment. There's actually a 4th category, which is a controversial treatment. That's not really the one you want to be practicing. ACT, in about 2011, for chronic pain, was given a grading of strong research support. That's the highest possible grading that's there. And to meet those criteria, essentially what that meant was that the database had to be robust enough that several studies that were not fatally flawed had been performed, which supported the treatment's work, that there were no conflicts of interest that were at least readily apparent, and that research must have been done by at least 2 completely separate groups of individuals. At the point when this grading was given, there were at least 4 groups of individuals who were publishing outcomes in this areas. There was our group, there was Julie Wetherell's group at the University of California, San Diego, there was a group at Uppsala University, and also a group at the Karolinska. Both of those latter 2 are in Sweden. At this point in time, there's probably 7 groups that are doing this kind of work. ACT is not in competition with any other psychological or behavioral approach, and is certainly not in competition with cognitive behavioral therapy. But what I will say is that if you look at this list of empirically supported treatments, ACT is the only one that has research support for chronic pain writ large, because the assumption is that the processes in chronic pain are the same that are keeping people stuck. Unwillingness, lack of clarity in values, directions, and kind of a lack of broader focused awareness and unwillingness to experience what is being experienced. Cognitive behavioral therapy, an absolute stellar treatment, has evidence for low back pain, migraine pain, and fibromyalgia. But the answer here is not quite sufficient, that ACT seems to work on average. Because patients don't want to know treatment works on average, right? They want to know, is the treatment going to work for me? Referrers don't want to know, does treatment work on average? They want to know, is the treatment going to work for my patient? Funders don't want to know, does the treatment work on average? They want to know, is it going to be a good investment of my financial resources? And what I'm going to do in the latter half of this talk is just try and illustrate for you the ways that we've tried to answer some of these issues. And I will readily admit that there is some statistical geekery going on here. What modern statistics really allow us to do is to look underneath the hood of our treatments to try and really determine what's going on in there. And I hope, as part of doing this, that it might help you understand, if you don't already, some of the ways that we think these treatments are having their effect. Does that sound okay? All right, thank you. I'm glad because I got 3 other talks ready to go. So if it's not, talk about something else. In effect, here's what we don't know. We don't know if the change matters. We don't know who's experiencing treatment success and who's experiencing treatment failure. That seems very important. As those of you, for those of you, all of you, who work in chronic illness, you know, in chronic illness, as opposed to infectious disease, we don't have a hard, clean marker of treatment success, right? Infectious disease, if the pathogen's gone, by definition, that's treatment success. Chronic illness, in chronic pain, what's our hallmark litmus test for treatment success? not sure we know. And finally, we don't know much about how treatment has had its effect. One way of trying to look at this, and this is a little bit of a stats lesson. If you absolutely abhor stats, feel free to check out, and I'll bring your attention back in a couple of minutes, if you want to. Some very wise people, a very wise psychologist and his colleagues, a guy named Neil Jacobson, who was a researcher in many things, but wrote these series of papers in relation to depression research. And he said much of the same things that I've been saying to you this morning. He said in depression, we don't really know what treatment success is because average effect doesn't tell us much about what's going on with the patient. And he derived or he suggested something he called the clinically significant change criterion. And this becomes relevant later, so I hope this little detour into statistics land is worthwhile. He said, what we want to know is if we're talking about self-reported symptoms, which is what depression is, which is what the primary characteristic of depression is, that people self-report it. Primary characteristic of chronic pain, people self-report both pain intensity and pain impact. He said, if we're measuring these things via self-report, we need to look at whether or not the change we observe is statistically reliable or reliable change. And I put a definition of reliable change here. In a statistical sense, this is change that exceeds change that could be accounted for by measurement error alone. It's a somewhat conservative way of trying to calculate a cut point for change. And if a patient's score exceeds that cut point, we can say that change is statistically reliable because it exceeds change that could be accounted for by measurement error alone. If it falls below that cut point, we could say that change could just be measurement error. He called that reliable change. He also said that really treatment success in depression is when we take someone who previously existed in a depressed continuum, a depressed distribution of scores, if you will. We've taken them such that by the end of treatment, their score on a measure of depression is indistinguishable from someone who has never been depressed. Does this make sense to you? Treatment success is, by the end, they look no different than everybody else. This he called clinically significant change, or clinical significance, excuse me. And it's worth just thinking about what we are here talking about today, which is chronic pain, and what treatment success, what is that distribution that a successfully treated individual with chronic pain would fall in at the end of treatment? It is unlikely to be they look like everyone else, right? Because the pain will persist. So it's a challenge that we have in our methods. In order to try and look at this issue of reliable change and clinically significant change, we collected some data and did some analyses. These were published a couple of years ago now in the Journal of Pain. We specifically looked at, there's a lot going on here, let me walk you through it. We specifically looked at 3 measures of functioning: depression, pain-related fear, and disability. We calculated various reliable change things, and if you're into statistics, this is just algebra, and sometimes this is fun for us. That's how pathetic our lives truly are. You derive a cut point after doing some algebra, and you feel like you've accomplished something for the day. Anyway, this is the required change to be classified as reliably changed. We then took that 3-year follow-up data that I just showed you and used that sample of data, their functioning at 3-year follow-up. We said that that's the best we've got to be representative of a group of high-functioning patients with chronic pain. All right? There are a variety of considerations. There are a variety of imperfections. But at the time, what we said was the data suggests 3 years after treatment, these guys are functioning reasonably well, so they're the ones who we're going to use. And then we derived a cut point, and if patients had passed that cut point, they were in that 3-year high-functioning group, and if they didn't, they were not clinically significant changed. Here's the data, and the data is sobering, I think. When you calculate reliable change, you can get reliable improvement, but you can also get reliable worsening. So you can get people statistically getting worse. When you look at clinically significant change, that's people who have both reliable change and their scores have shifted. And if you just eyeball these data, you'll see a few things. That in this, what I would like to think of is a top-of-the-line treatment, or at least a treatment that is delivered from the heart and from the science to try and be top-of-the-line, that the vast majority of individuals have no change. Not the vast majority. Gosh, that's a little bit of an overstatement. 60%, 63%, something like that, have no change. And part of that is because of the conservative nature of this way of analyzing change. We have approximately 5 to 10% of people who have reliable change only, and then about 1 out of every 4 who give us evidence of clinically significant change. We can also look at this by looking at the people who fell in that clinically significant distribution at the onset of treatment, so only the people who were really in that other distribution of being highly distressed or highly disabled. And the numbers get a little bit better, still approximately 1 out of every 2 giving us evidence of no change, about maybe 13% on average reliable change only, and about 1 out of every 3 to 4 individuals giving us evidence of clinically significant change. Numbers like these keep me up a little bit at night. However, I would put these kinds of analyses up against a lot of other interventions out there, and I suggest to you that these data would fare reasonably well. That if we're really taking a good hard look at our data and trying to determine who is so much improved that they are now indistinguishable from other individuals who never showed up with that disorder, that the data from other areas might look the same. One other way of looking at this is to look at the number of patients who had reliable change in 1 or 2 or 3 of our measures, or reliable change in more than 1, to do the same for clinically significant change or clinically significant change in at least 1 of these areas, and to do that for patients and then patients whose scores fell in the clinical range. Here's what those data look like. They look a little bit better, so this is what allows me to sleep a little bit at night. Total reliable change in at least 1 measure, approximately 6 out of every 10 patients. Total clinically significant change in at least 1, about 1 out of every 2 patients. Again, those numbers improve a little bit as we look at only those patients who were the most distressed and most disabled at the onset of treatment. So that we're seeing some shift here, and some fairly significant shift using a conservative way of looking at treatment. What I'd like to do, I have no idea when I'm supposed to be off. I assume someone will tell me I'm doing okay. Wonderful. I feel okay. Here's what last thing I want to talk about is how does treatment work? And to look at some potential mechanisms by which treatment works. And I think this, I hope you agree, I think this is important and intriguing. Common sense model of human functioning would suggest what we need to achieve successful treatment is both a decrease in pain intensity and a decrease in distress. Common sense kind of suggests that's what we're shooting for. We did some most sophisticated analyses I think I've ever done to try and look at this over the course of a 4-week, highly intensive intervention for individuals who had chronic pain. Duration was approximately 6 hours of active treatment content every day, 2 days a week for a period of 4 weeks. As Dr. Ballantyne discussed earlier, this kind of treatment is really best for individuals who are the most complex, the most highly distressed and most highly disabled. What we asked them to do simply was every week tell us how bad their average pain was over the past week and how bad their average distress was over the past week. We wanted to know how trajectories of change over the course of treatment were related to functioning at the end of treatment. Put in more simple, hopefully more comprehensible terms, we wanted to know on average do most patients experience decreasing pain over the course of treatment? And the individuals who get greater decreases in pain, do they do better in treatment? Or do they do the same as the people who've left treatment and their pain's the same? Same thing for distress. We wanted to know, individuals who get less distressed, do they just do better in treatment? Or do they not do better in treatment? This was, without boring you too much, something, it's a term that rolls right off the tongue, growth mixture modeling. I'm sure you talked about it over cocktails last night. It's that common. Growth mixture modeling is a way of doing exactly what I just described, looking at change trajectories to try and determine how important intra and inter-individual change is in the prediction of outcome. Rather than bore you with the details of this, I'm just going to tell you what we found with regard to changes in pain and distress and improvements in functioning at a 3-month follow-up. We found that trajectories of change in pain and distress were unrelated to treatment-related improvements in physical disability, psychosocial disability, depression, pain-related fear, pain acceptance, values engagement, observed physical functioning. We asked people to walk and to do a sit-to-stand task, and a number of pain-related medical visits. In other words, from a statistical perspective, changes in pain and distress had no statistical relation with improvements observed over the course of a treatment program. I think that's interesting. And it may be, I won't get to talk about this much, it may be a product of the treatment that we provided, which was a treatment that said, pain and distress are horrible. We don't want you to have them. And there's life out there, and we want you to have that. And what we'd like to structure treatment around is how to get back to living, and let's see what pain and distress do. So it may be that we were teaching to some test. Last couple of minutes I have here, I just want to talk about one other set of data. Before I move on, though, there were two exceptions in this pattern of finding, which was that pain-related anxiety was absolutely related to pain trajectory. Individuals who had greater decreases in pain over the course of treatment had greater decreases in pain-related anxiety. And change in distress was related to changes in psychosocial disability at post-treatment only, actually. So people who had greater reductions in distress had greater reductions at the end of treatment in psychosocial disability. From the perspective of the ACT model and of other models, we might say there are different processes that we're trying to shift in treatment. We might say things like, rather than trying to change pain intensity, we're trying to change something we might call pain willingness, or openness to pain, or freedom in responding to pain. We might also say that rather than trying to change things like distress and pain intensity, what we want to try and do here is get greater engagement in the activities of life that bring satisfaction, vitality, meaning, quality, etc. to this business of living. From the perspective of this model, we would hypothesize that when we see those things in treatment, more pain willingness, more engagement in values-based functioning, that ought to give us this stuff, and it maybe will give us that stuff even with continued pain. Because we want our patients to live a good life. I mean, we want them to be living a good life when pain is low, right? But man, we want them to be living a good life when pain is high, too. And the nature of pain, I don't have to tell you, is that it is incredibly unpredictable. Sometimes it's low, and sometimes it's high. So what we know from the literature that's out there is if we get more willingness and more engagement in values-based activity, that is associated with better functioning now. It's associated with better functioning in the months and years that follow. And if we can derive treatments that change them, changes in willingness and engagement in values-based activity are reliably associated with improvements in functioning in the months and the years that follow treatment. These are some graphs. I'm going to show you some graphs that I showed during last year's talk and then give you an update of what those data seem to suggest, and I'll be done in about 5 minutes. Early on, we asked only about pain and distress. And as time moved on, we started asking about other things like, how much are you unwilling to experience pain? Or how much have you struggled for pain control over the past week? So things like, how willing were you to experience pain and distress in the past week? How much effort did you put into making pain and upsetting thoughts, feelings, memories go away this week? How much were you fighting against these things? We also asked about, in the past week, how much have you engaged in activities that matter to your life? So how effective were you in taking actions that contribute to a better, more vital quality of life in the past week? How effective were you in making progress towards those areas? And from the perspective of this model, right, unwillingness ought to come down over the course of successful treatment, and engagement in valued activities ought to go up. I'm going to show you the data just from 3 patients and then summarize the cohort analyses that we did here. This was a woman in her 40s who was diagnosed with fibromyalgia. We have our 4 weeks of treatment down here on the x-axis. We have our 0 to 10 here, and we have 3-month follow-up down there. When we tracked pain intensity over the course of 4 weeks of treatment, it moved around a little bit. That's totally fine. When we asked about struggle with pain and distress, something interesting happened early on, which was that it absolutely spiked. It got worse. This woman was struggling more in the middle of treatment. And this is not, from a clinical perspective, this did not surprise us because it is not uncommon for individuals when they come into treatment to start to feel worse as they begin to come into contact with things that they've been trying to avoid for sometimes years or decades. If it had stayed up, we would have been worried, but that's not what happened. It came right down such that by the end of, or by 3-month follow-up, it was very low. Talk about engagement in valued activities. We want that to go up and stay up. And that's exactly what happened. And so it's hard to say, hand on heart, this is treatment success. But this pattern of change ought to be predictive of treatment success. Less struggle, more engagement in valued activities. And when we looked at outcomes in this woman's case at 3-month follow-up, we saw at least significant improvement that was consistent with the judgment of treatment success. Reliable improvement on the sickness impact profile, a decrease in values discrepancies such that her behavior was more in line with what was important to her, and then a nice reduction in pain-related medical visits from 5 to 0. Patient 2, this is a gentleman who was a little bit young, was in his 50s, was a school teacher who retired because pain was doing weird stuff in his neck. And these are the 4 weeks of treatment. We see that pain came down a little bit over the 4 weeks of treatment. That's fine. No problem with that outcome. Struggle came right down. Engagement in values-based activities came up. When we look at 3-month follow-up data, pain had come back just a little bit or gone up just a little bit. Struggle had gone down, engagement in valued activities had gone up. Again, that pattern of findings ought to be indicative of treatment success. When we looked at outcomes, they seemed to be concordant with that interpretation. A reliable change in disability, a decrease in that discrepancy between areas of importance and success in those areas, and a nice decrease in pain-related medical visits from 15 to 2. Of course, treatment doesn't always work. There's a guy in his 30s who continued at the end of treatment to experience significant levels of pain unwillingness, significant levels of pain intensity, and although valued activities were reported to have gone up, we were worried that within this context of significant struggle, it was unlikely to be sustained once treatment ended. We look at 3-month follow-up data, what we see is that things seem to have crashed and that this is unlikely to be a beneficial or a successful treatment outcome. When we looked at those 3-month outcome data, they too seem to suggest this was not a successful treatment. No reliable change in disability, small shrinking in importance and success in these valued areas or the discrepancy, no change in pain-related medical visits. We then followed this up in a very small sample of patients, 21 patients who we tracked very carefully through treatment and on a 3-month follow-up. And in essence, this is what we found. In the form of a logical statement, if there was change in valued activities, if there was change in struggle and valued activities, then there was reliable change in disability, reliable improvement disability in 8 out of those 10 individuals who had that pattern of change. In other words, if there was a decrease in willingness, an increase in values, 80% of those individuals had a substantial reduction in disability. 20% did not. When there was an absence of this pattern, in other words, when struggle and values were unchanged, 9 of those 11 individuals, 9 of the 11 individuals with that pattern of change experienced a lack of reliable change in disability. Small sample, but potentially at least a window into something that could be going on in treatment that is worth paying attention to. The epilogue to that story is we also looked at changes in pain intensity. This is individuals who had a reliable change in disability, individuals who had a lack of reliable change in disability at that 3-month follow-up, and 2 of the individuals with reliable change reported decreased pain, 7 the same pain, 1 worse pain. Those without reliable change, 5 reported decreased pain, 6 reported the same pain. And as I look at these numbers, maybe as you look at these numbers, this is not interpretable, right? There is not a reliable relation apparent between change in pain and change in disability. So just to summarize here, psychosocial treatments absolutely appear to work on average, and they appear to work via the process of action change, behavior change. It also seems important to explicitly state our success criteria and make it distinct from our failure criteria. In other words, if we see a patient at follow-up, how do we tell whether or not they're a success or a failure? And to do statistical geekery tests, to expressly test mechanisms of treatment effect so that we can better highlight them, and if these mechanisms are important, we can better structure our treatments to direct them and to move them. Last slide here. One way of thinking about this particular behavioral approach of acceptance and commitment therapy is that we can augment willingness to have the stuff that we don't want, the stuff that no one would want, because it's the stuff that people have. And if we can't get rid of it, then we might as well try and make people more willing to have it in the service of the things that matter. And we have a treatment technology available to us now that seems to be able to successfully do that to some extent. And when we're able to do that, that's associated with improvements in functioning over follow-up periods that are typically 3 to 6 months. We also, within more interdisciplinary rehab settings, have these 3-year follow-ups. There's a 15-year follow-up study as well. And this is my understanding of this thing we call ACT. We don't tend to call it ACT, although Dave can because I like him, because that sounds like ECT, electroconvulsive shock therapy, and it's a little bit different, but maybe we could do both. Final thing I'd like to do is show you my daughter when she was younger and a little bit cuter. And thank you very much for your attention. Thanks very much.